Hello everyone, welcome to the Voice of Nursing. My name is Adrian Tracy, CEO of ICG Medical. Today we're very lucky to be joined by Mark Foulkes.
Hello.
Mark, welcome to the Voice of Nursing. Tell us a little bit about yourself and about the role you do.
My name is Mark Foulkes. I'm the Macmillan lead cancer nurse at the Royal Berkshire in Reading, and I'm also a nurse consultant working in acute oncology, which means that I spend half my clinical time going out, all my clinical time going out seeing patients who are brought into hospital with as an emergency admission related to their cancer. So that can either be people who have a known diagnosis of cancer, who have side effects of treatment, or it could be people who are admitted with a problem and it turns out to be a cancer. So we see those patients and try and reduce the length of stay and try and make their journey a little bit easier and give advice. So that's my clinical part of my job. The lead cancer nurse part of my job is a bit more nebulous. I mean, I'm like a senior nurse for the organisation, and nominally I suppose I'm in charge of the standard of care for all cancer patients in the trust. Of course, well, that's an impossible job. So it's a matter of networking with other nurses and, of course, medical staff and with the organisation to make sure that the standards are good.
Mm-hmm. Tell us, how did you get into nursing?
How did I get into nursing? Well, that's a good question. Well, the first thing to say is my mother's a nurse and quite a senior nurse. She was like a district nursing officer before she retired, and she always said that, "Oh, you'd make a really good nurse." And when I was like young, I was, "No, why would I do that? I can't think of anything worse." And then I went to university and did my degree, which is in biological sciences, and then I sort of finished that and thought, what do I do now? I don't really want to work in an office. I don't really want to work in a lab. I want to be out doing things. The other thing, I'm quite a political animal, so I wanted to do something useful. I wanted to feel as if I was doing something that was worthwhile. So I thought, I don't know, maybe that nursing idea wasn't such a bad one. And I sent a whole range of rubbish application forms off to various schools of nursing. And there was only one that interviewed me. But I mean, my basic pitch was, I know nothing about this job. I think I might be good at it. Do you want to give it a shot? And the only one who took me up on my offer was St Mary's in Paddington, who said, come along. And
obviously worked.
And they liked me. And then I started nursing, and it really suited me, and I've not really regretted that decision ever since. I mean, it's been a really good job.
And talk us through the career, how you started off and then how you then moved into the oncology area, or the sort of specialist space.
So I trained I did general nursing at St Mary's School of Nursing in Pancreatic, it was then, and from there I went very quickly. I don't know, something about male nurses is they're drawn to these technical areas, and there's an expectation that you'll go into technical areas. So I ended up sort of working on a very intensive surgical ward with like a high dependency bay in it. So there was lots of observations. It was like major pancreatic surgery, and even though it was okay, I wasn't really enjoying it. It was like, oh, this is okay, and I was a good staff nurse, I think. I worked hard, but I didn't have a natural feeling for it. I felt like I was doing things to people, so they're sort of with them. So, and there were a lot of people with cancer on the ward, a lot of patients with cancer diagnosis, and I felt that I was more drawn to them as well. So, because obviously they were quite distressed. So then from there, I did what was a specialist cancer course then, and I did that at Charing Cross in London. And then I stuck around Charing Cross after doing that course, doing a range of jobs, from like being sort of charge nurse on the ward to practice educator. I was a palliative care nurse for a while, clinical nurse specialist. I wasn't much good at that, to be fair. And then my sort of the last job I did was as a clinical nurse specialist in looking after people with brain tumours and with people with head and neck tumours. So it was a mixed job. I set up the head and neck CNS service there, and that was really great. I mean, I really loved doing that. It's a very busy job. And then I got married, and sort of it became obvious that we weren't going to be able to live in central London because you didn't have any outside space and having children. So we moved out to Reading, and I've been in Reading for 13 years now, something like that. Reading, I've done a range of stuff. I was employed as the modern matron there. It was the very modern matron, and I did that for a while. I also worked while I was doing that as a clinical nurse specialist, carried on looking after people with brain tumours. I then switched out. I was it was the cancer targets were launched, and I jumped out of nursing for a while and covered some maternity role looking after cancer targets as the cancer manager, just as it was brought out. It's a very hectic job, and then after that I was an ops manager for a while, because they did that health service thing where while you're away doing something in the secondment they get rid of your original job. So my sort of matron job sort of disappeared, so I had to do something. So I thought, what should I do? So I did ops manager. So I was ops manager of the cancer centre for a while. I did that for a couple of years, and once again wasn't quite my thing. It taught me a lot, but some might say my financial management wasn't the best.
But the care was good.
And I enjoyed elements of it, but it wasn't for me long term. And so after that, and when the opportunity came to go back into nursing as a senior role, I became the lead cancer nurse and nurse consultant mixed role, which has been great for me. Really good, very varied, which I like, because I've got a very low boredom threshold.
I was going to say, it sort of leads us nicely on. What's the sort of most challenging, sort of interesting parts of your job?
Well, the best parts of the job, without a doubt, are the clinical bits. So I think you need to keep. I'm really strong believer in keeping on being a clinical nurse, because if you stop doing that, then you lose touch with what's going on out there. And I really like that, and I like to keep my clinical practice up. I think I'm a prescriber, and I've got medical examination skills, so I can do all that. I'm fairly autonomous, which is great. The job that I do is very valued both by the patients and by the people I work with, which is great. The most challenging things that I'm facing at the minute are around sort of long-term future of cancer nursing, I suppose. It's about challenges around workforce, where cancer's been lucky, and it's provided a place for senior nurses to be, and they've got a very, very sort of well prescribed role, role in cancer MDTs. They're very valued. There are lots of services are built around them. But those clinical nurse specialist posts those nurses are aging. I mean, I'm aging, but and that's my background. And soon, in about 10 years, I think the Macmillan Cancer Nurse Census showed about 35%, in some areas even more than that, we're going to be retired in like 10 years. So there's going to leave a massive gap, and that's a real challenge. But also there's all sorts of other recruitment difficulties. Are really, really strong. And part of the reason why I agreed to do this is because I think cancer nursing and nursing generally is such an important thing for society that we do need to get out there and recruit people to it, and there's lots of campaigning about getting more men in nursing and I think just get more of everybody into nursing to be because it's such a great job, and a lot of people don't consider it when perhaps they could do. I don't think we have to change the way nursing is. I think there's lots sort of men in nursing campaigns saying, we made it to make it look less feminine and more sexy somehow. So it's like, that's crap. What you got to do is change society's view to value it more. I think that's what's happened in the last
it always kind of comes up as the number one trusted profession.
Well, which is great, but and I always think it's funny. When you've got things like programs like Casualty, 24 Hours in A&E, anything like that, and they're all got great viewing figures, and like everybody says, well, why do you want to do that job then? People go, no, couldn't do it. It's like there's not an extra step there, is it? It's got massive appeal, but then why don't people want to do it? I think it's because people don't value it higher up in society. Government doesn't particularly value nursing, I don't think. I don't think that society as a whole over the last, people value nurses when they meet them, but the society as a whole doesn't value the contribution of nurses as much as it should do and has done in the past. It's a more selfish society, I think.
Possibly. I think nurses are taking a bigger role there in clinical practice, aren't they? You know, the years ago where the doctors used to do a lot of that, where you have surgical nurses, nurse prescribers. Yeah, they're taking a lot more of it, so nurses become even more valuable, you know, in that sort of setting rather than less.
Yeah, and I think we've taken on those roles because we've been keen to do it and also fill gaps in, and we've freed our medical colleagues up to do other things, and I think that's right. I don't have a problem with that, but now we're in the same position because there isn't going to be enough of us either, so what we're going to do then? So now we've got, on oncology, we've got massive gaps in recruiting oncology doctors, but also we're approaching having similar problems recruiting chemotherapy nurses, clinical nurse practitioners, people who want to specialise in cancer nursing. The numbers are dwindling, I suspect, as they are in many other specialities like renal nursing or cardiology. There'll be similar problems, and that's because there's not a supply of nurses who want to do it.
It's probably getting worse, if anything else, as you say about retirement, and you know, a lot of European nurses are going back, aren't they?
Yeah, I mean, I want to. Yeah, that really, the whole Brexit debacle hasn't really helped. But I think that I don't want to be negative. I think I'm very positive about nursing, and I think my view is that if we were to be able to appeal to people on a personal level and say nursing is a great job, you should really do it, because there's lots of. I mean, if you want to meet people, you like to talk, you like to interact, and you're caring, and by that I mean most people are caring, really, aren't they? I mean, I really think that most people are caring. No one would describe themselves as uncaring, would they? But I mean, as long as you can get that, you can use those skills that most people have in an interesting way. You can find there's somewhere in nursing for you.
I suppose one of the challenges is the cost of studying, isn't there? And you know, the bursary comes up quite a lot. And I obviously know Scotland and Wales have, developed a different strategy.
It's been a disaster, hasn't it? I mean, I don't know what they were thinking of. I have no idea about why England has ditched the bursary. It doesn't make sense. I mean, it's got to be money, hasn't it? It's got to be financial. And in fact, if you look at Scotland, a great example. I don't have the Welsh facts to my fingertips, but Scotland have been very successful because not only have they kept the bursary, they've increased it, and therefore they've managed to appeal and keep their levels of nurse recruitment up. In fact, it's increased, I suspect, because people from England are going there to do it. And why shouldn't they? Because you've got to be able to live.
Yeah, I suppose the difficulty as well. We interviewed Ewout, who one of the students.
Yeah, I know him actually.
Really good guy, and he was saying, because what we probably don't appreciate, if you're not in the nursing world, is when the nurses are doing their studying or their exams, you still have to do your practical work, your placements, but that's all unpaid. So it's not like you can have a side job to then help you get through that that financial burden, because you're working as well.
I mean, a lot of people do work as agency, but I mean, my view is you shouldn't have to do that. I mean, I think that if you want, if
there's time as well, though. Where do you space in the time of studying, doing your placement, and then having to work as well to provide? It's very, very difficult.
I mean, if society values nurses, then that should be funded, because people are working. They're not as if they're drifting along. Not as if it's an esoteric subject. It's very, very practical. And I strongly believe that any strategy that we have to develop has to involve a replacement of the bursary to encourage people to go into it, and it has to have a broad appeal. It can't be, in the past people said, young women need to be recruited into nursing, and in the past it's been largely middle class white women recruited into nursing. We have to spread on it a lot wider than that. I think we have to be a lot more appealing across all of society.
Well, society is different. Your patients will be different.
No, you're right. You're right. Nursing has to reflect the people who you're looking after, doesn't it? Yeah. Otherwise, you're severely out of step. And I think some people in the sort of like older people, perhaps even in universities and in NHS trusts, think that we can carry on recruiting the same sort of people that we've recruited in the past. Well, we can't. We really can't.
Not working successfully.
That way. We have to have a much broader appeal and make nursing. Well, not make it. You just have to show what a good job it can be. And I'm testament to that. I love my job. I don't get up out of bed thinking, I've got to go to work today. Never happens.
No, you notice that with a lot of the people we've had on this, you know, the passion they have,
Yeah.
and also the varied career.
Yeah.
You know, the different things that people end up going and doing. You know, it's like you all start off as sort of, you know, you're a general nurse, and then you go to so many different areas. It's such a varied career every 2 or 3 years, and you're encouraged to do that as well.
Yeah, well, I think it's a privilege, isn't it? I regard it as a privilege to look after people particularly when they're going through hard times. And I think when people are often at their best when they're going through hard times. I think, people say, a lot of thing about, I get really annoyed about this sort of thing, and there's some research out about how annoyed patients get at being battling cancer and things like that. It doesn't feel like that when you're there. My experience is looking after people for 30 years now, people with cancer, is that's not how they feel. They feel they're just in a position where they've got to crack on with it. They're left in a position where you've got to get on with it, and that puts them in a very difficult position. But also, the bravery is a different sort of bravery. It's not the bravery of the battler, it's the bravery of somebody who just has to cope with everything that's being thrown at them. And that some people, most people are brilliant at it. I mean, it's such a privilege to help people in that position. I feel very strongly that often people, when their backs on the wall, people are really, really great. Actually,
come out fighting.
Yeah, fighting, or come out different. Come out different. They do come out different. I mean, there's lots of people living with cancer and a lot of people surviving for many years. And we reached a point, I think, a couple of years ago, where more people survive to 5 years than die of cancers now, broadly. So that's a testament to the success of treatments. But that means that a lot of people are living with these diagnoses now. I think that's another massive challenge for us. And as our treatments get better, it stands to reason that more people will be living not only with their cancer diagnosis and what that does to you psychologically, but also the side effects of whatever treatment we gave them.
Yeah, it's more 1 or 2 or 3 or 4 different issues, isn't it? They come and see doctors with now, not just like one issue.
Yeah. Multiple morbidities, and of course, as people get older, I've definitely seen this over my career in nursing. It's like older people are just so much fitter. You can meet 80, 85-year-olds, even 90-year-olds who are pretty fit.
Yeah, no, you do.
People cycling, getting on with it, and they you wouldn't say, it's a 90-year-old, you can't offer them treatment. That's just not the case anymore. You have to apply it to the person. Yeah.
Tell us a little bit about your role as a board member for the Oncology Nursing Society, or is it UKONS? Yeah, I'll get it right. Yeah,
UK Oncology Nursing Society. Well, it's very exciting. I think UKONS is a very accessible and very important voice of cancer nursing. They've got lots of important work over the last sort of 5-10 years to help cancer nurses do their job better. I mean, we've got things like lots of work in acute oncology. The biggest thing, I suppose, they're famous for is the UKONS triage tool for people who phone in with cancer-related side effects. It's like a telephone triage tool, and it scores people. It's been really successful and very well evaluated, and most hospitals in the UK and indeed across the world use that now to assess cancer patients. That's really good. Got also something called the SAC passport, which is like SACT is the new sexy way of saying chemotherapy. Systemic anti-cancer therapies, because chemotherapy is much more sorts of chemotherapy than there used to be. But there is, because there's been, over the years, there has been sort of lots of variation in the way chemotherapy nurses and people who give these drugs are trained. And what UKONS has done over the last 4 or 5 years is along with others, is to produce what we call a passport about what to make the training more uniform, make the skills more uniform, make the competencies more uniform, so you can carry that around with you. And that's been a big piece of work. Also got acute oncology, my old field, sort of very good guidelines now. So there's whole ranges of stuff, ranges of work that we're involved with. I mean, I think the interesting thing is now we've got all these specialist things. My interest is around workforce planning and around education outside of those specialist areas, is to give nursing a more of an appeal, and cancer nursing in particular appeal. So I think we can't wait until people are in cancer nursing UKONS needs to have a role of attracting them in.
And how are you going about doing that? How would you recommend someone to pursue that as a career?
Well, I think we have to get out there. I think think we have to produce materials and education materials that produce the. I think there's lots more interesting things you can do. Well, that's the sort of thing we're doing here, isn't it?
Yeah.
A lot more interesting ways of producing educational material than simply just putting it in a booklet or having it on a university course. Those days are gone. You need to be able to promote the tools. So if somebody wants to be, say you're a student nurse, and you think, oh, what would I want to do for a living? It's like, when I grow up, what do I want to do for a living? And I think oncology nursing has to be a part of that. And then when people start looking at that, you've got to give them an idea what that might be like. And I think that's my interest, is trying to target education and promotional materials at those people, so they can also have a look at the skills they might have, maybe even have a taste of access what that might be like, and become involved in cancer nursing from a very early stage, not just when they're already there. And I think the other challenge for me, I mean, I've got a bit of a large job on the board at the minute, and that's to look after our education strategy. That's one could say that's the biggest role of UKONS. I mean, that's a key element, isn't it? Is that our key role is to provide education for nurses, and I'm sort of looking after our strategy for that and try and pull lots of that together. And I think the other thing we have to do is all these people who are living with cancer, how do we nurse them? They're not in traditional environments anymore. They're gone. They're out living their lives. But how do we provide support for those? I think it's an interesting a challenge to cancer nursing how we do that.
So is that going to be like oncology at home?
Yeah, it's exactly what it already is. Yeah.
Okay.
So it's like, how do you, if you want advice around, say you're a patient with breast cancer, you want access instantly about you've got a problem. How do you access that help? Who are you going to call? Who are you going to contact? How nursing can respond to that, what tools patients might use to do that, and how, if they've got a serious problem, how that might be flagged up, and what they might have to do about it and guide them. So that's a big challenge for nursing, a big challenge for society, but a big challenge specifically for nursing that I'm interested in, and how we might deal with that. So I think we can no longer be just doing very traditional things in terms of cancer nurse education. We have to be much more imaginative, and and time's already moved on, isn't it? The idea that you go to a university to do a course is now, it's very rarely happens. You might go to the odd day at the university, but a lot of it is online resources and guided learning and chat rooms and contacting others. So, and even though I look impossibly old, I'm actually I'm quite on board with that. I think technology.
Yeah, you're on Twitter and all. Yeah.
I'm like a Twitter rash. I can't be stopped. My friend and colleague Jess Higston, who's a matron who I work with, she introduced me to Twitter about 18 months ago, and I've just gone crazy with it.
Nothing wrong with that. We like Twitter.
Yeah, well, I think it's been a revelation. I mean, it's been such a good way to network, and the way it works is so good. If you're smart, and hopefully I'm smart, is that you can promote. If you promote things the right way, you can get enormous reach.
Yeah, no, you do.
I'm doing a bit of work. I've probably overdone it slightly now, but I'm doing this piece of work where I've been asked as part of UKONS to turn up to a sort of NHS England roundtable discussion about how multidisciplinary team work. So I thought, I can't just rock up and just have my own view. I mean, my own view is obviously great, but I need to capture other cancer nurses' views, so I'll stick it on Twitter. So now I've got like loads now. I've got everyone's views now. So it's gone completely crazy. So Twitter's really good at that. If you can capture views very, very quickly and network really fast, and so that's been great. So thank you, Jessica.
What do you think the sort of main trends that are coming out in nursing over the next couple of years we should be looking at? Sort of three trends do you think are the highlights?
Okay. I think that patient safety is going to be huge. I think there's always been issues around about how patients are kept safe in hospital, but also outside, and how nursing can respond to that. So people you have to be able to not only keep patients safe, but proving that keeping patients safe. So I think anything that involves sort of infection control, anything that for staffing levels, getting safe staffing levels is a big thing, I think, and how nursing responds to that. I mean, I think there's been lots of talk about we just have more physicians assistants, we'll have more nursing assistants, but that's not going to help forever. At some point you're still going to have trained nurses, so that goes back to workforce plans. That's a huge issue. So it's about how to keep patients safe, how to have safe staffing levels, how we might deliver that, and that's a big challenge. I think using technology in nursing is massive. I think that if I'd have chosen a field to go into when I was a nurse that wasn't cancer nursing, I would probably, time over again, I would definitely do something in technology, because nursing and technology is a really good fit, actually. Using things like electronic records. I mean, I've seen that transition from x-rays and notes and everything over the last 20 years. It's completely changed. So now I'm working in an environment where all our chemotherapy is delivered on an electronic system. It's signed for, it's prescribed, administered all on electronic records. All of that's much safer. You don't lose. So all of that technology will continue, and how nurses use that technology but don't lose the essence of nursing. Because now what I see when I walk on wards, it's like lots of nurses looking at screens. It's just like, I can see what's happened, but it also makes me feel a little bit sad, because people are hiding behind them now.
Okay.
So that's what I think, because you have to, when you do obs, you can sit next to your patient, take some observations, and then you can write them on the chart. You still be sitting this. Now you have to get up, walk over to the chart, and then walk over to the computer, tap on. Even when I'm talking to patients, I've got my, what we call them, cows computer with wheels. They're not actually a cow, but they're computer on wheels sat next to me, and it's like my friend. It's quite intrusive. So it's how we use the skills to talk to patients and keep that very important nurse-patient relationship while using technology. So the obvious thing is to use things like dictation technology, or use like pads instead of these dirty.
Yeah, the big iPads and stuff like that. For 3 or 4 years.
Or it's got to be dictation, isn't it? It's got to be like, I've just seen the patient, I've spent this, voice recognition, voice recognition's the way forward. So all of that is really interesting. I mean, from my own point of view, from my own specialist area, I suppose. So not my mic then, didn't I? Anyway, but from my own specialist point of view, I think the real challenges are real sort of ways forward are around chemotherapy drugs, agents. We're at sort of a lot of like a druggy week at the minute. Immunotherapy is just a fantastic field in oncology, and we're in a position where chemotherapy nurses have had quite a limited range of drugs really for like 30 years, which all have very similar side effects. So things people like hair loss, nausea, make your white count dip. Now you're given immunotherapy and targeted therapy. You have a whole range of different therapies. They mess with your pituitary, they give you colitis, they give you pneumonitis, or your major itises. And how we respond to that, we have to train people differently. And also these drugs are going to have applications outside of cancer nursing. So there's a whole, we're looking with where we are in cancer nursing at the minute. We've reached the top of the hill, and we can see into the distance that it all looks very different. Let's take two tumour sites, lung cancer and melanoma. There was not too long ago when both of those tumours were basically a death sentence. Particularly metastatic melanoma would have a very short prognosis, but now with new agents, people can be living with for many years.
Aren't they talking about pancreatic cancer? They might have
well, that would be great, wouldn't it? Because pancreatic cancer is still very difficult to treat. And many of the patients that I see on an acute oncology round turn out to have pancreatic cancer. Often they're quite elderly, and that's a very poor prognosis. But I think in due course we'll have more treatments for these cancers, but also those treatments are very personalised. They'll be based on people's genetic makeup. So we're already very, very frequently testing people's genetic makeup to find what drugs we can give in order to target those genes, and that's just going to get more and more prevalent.
Yeah, a good friend of mine's going through it at the moment, and they said he's like his third different mix of drugs, but they say they do it relevant to his fitness and his age, and you know how he.
Yeah, it's all tailored.
Yeah, literally, like personalised care.
Yeah, absolutely, and that will be the next thing in cancer nursing over the next 10, 15 years. Be the element to which we can personalise care, element to which you can personalise the drug and the treatment you get. I mean, there's also, it'd be wrong of me not to talk about radiotherapy, which is like lots of advances in radiotherapy, lots of sort of clever ways of giving radiotherapy. It's a really good treatment, very well tolerated treatment for most cancers, and there's lots of interesting things like proton therapy and how we deal with that. So it's a great time to be working in cancer. I'm giving it a good massive pitch, aren't I?
Give it a go.
So come and join our happy gang in cancer nursing.
Tell us. So I know you appreciate you're busy at work, but tell us a bit about what you do outside of work in your free time, if you've got it.
Okay. Well, very irritatingly for my whole family, I don't necessarily draw a very clear distinction between my work life and my family life. So you know, I'm not a big one for like when I finish work. I don't really like that. I do lots of things. I do lots of work things in my spare time. But when I'm not doing that, I'm a massive music fan, so I run a monthly music night at an art centre. I'm a bit of an old punk rocker, basically.
Yeah, okay.
It probably won't surprise you to hear that. And I run a monthly night which specialises in what I say hard to classify musicians, but basically mad people who play. Yeah.
Is that
So I've played in bands myself after a fashion.
So what punk bands? The Clash and people like that?
I've got a very broad church. I'm more interested in things like what bands am I listening to, like the Idols, like Fontaines DC, so very modern bands. Yeah, okay. I like to keep myself abreast of affairs, so there's a few people I've booked who've gone on to do bigger and better things. Sandara Karma, somebody I booked for one of their first gigs, and then they're playing Reading. So
you get a free ticket?
No.
Surely they give them to the hospital, don't you?
That's a thought. So I do that. I also I'm a very keen cyclist. My bag's over there with all my cycle kit, and I hate driving. I can drive, but I hate it. So I'm always on my bike. A few years ago, myself and a doctor cycled from Reading to Barcelona for charity on a tandem. That was good.
How long did that take?
2 weeks. Well, 13 days of cycling and 1 rest day. So I love all that. I love being out and about. What else do I do? I like swords. I fence regularly every week. Yeah. So I think I'm quite active, quite outdoorsy.
That's an interesting mix.
Yeah. I suppose I'm quite a bit eccentric, really. I suppose people regard me as being a bit of a nutter. I think I'm looked on where I work with sort of generous bemusement.
I suppose just finishing off, Mark, is there any message you'd like to give to our nurses, or indeed our cancer nurses out there?
I would think, well, 2 things. Firstly, get involved with UKONS, who are very open to and help sort of mould the society into what you want it to be, into what we can do for you. But also more broadly, cancer nursing is a fantastic job. People should really consider going into it, and if people are interested in that, they can speak to me personally and I will help them. I think that nursing is a great job and it suits everybody. It's a really important job.
Super. And where can they find you on Twitter?
They can find me. It's a bit of a weird handle, but it's M_worm, because I used to be in a band called The Worms.
Very good.
It was the most un-rock star name we could think of, so I kept that Twitter handle now. So yeah, but you can find me.
We'll get it on the bio.
Yeah, put it on the bio, or you can just email me at the Royal Barts. Yeah,
very good.
It's fun.
Thank you for watching The Voice of Nursing. Thank you to all our nurses, doctors and carers for looking after us all. We'll catch up with you again soon.
Can't agree more. Thank you very much.